So with that, Dr. Chien, reflecting back on all that your team accomplished with TeamBirth, what are some of the positive outcomes from implementing TeamBirth at your facility?
Well, we've had so many, I have to say. When we first started TeamBirth, it's a challenge. Like, I commend all of you for starting on this right on the heels of COVID. For us, we started on the project because we had been tasked to really try to work on our NTSV C-section rates. By that point, I was like, that's like a dirty word, NTSV C-section rate. I was so tired of hearing it. And we approached Ariadne Labs to say, hey, we hear you have this innovation. You have something in the pipes that may help us standardize care and may help us reduce our C-section rates. And then they gave me this printout of a whiteboard, and I was like, well, this is it. So then I realized, though, it's a lot of behavior changes that come with it. I think one of the biggest things that we learned right away from TeamBirth and opening up the way we communicate to be back at the bedside and including patients and families in the conversation is that the patients had a much better birthing experience from that right away. And I think that was clear even before we started to see any differences. I think that for the nurses, it was great because there was so much better clarity as to what the plan of care was. I think when you're standing at the bedside, you're having to document on this whiteboard what the plan is for care of the mom, for the baby, and what the plan is for labor progress. And you kind of have to commit to, well, this is when I think I'll be back roughly, or when I'll check in again. I think for the nurses, like, that was a really big boost to the morale. One of my very good nurse friends said, after we started TeamBirth, I truly believe we started giving the best care we've ever given at this institution. And she's been there for 18 years. So I think that was a huge boost. And then incidentally, as we started to be more consistent with doing huddles, over time, we did see a decrease in our NTSV C-section rate. The statisticians would say not statistically significant, but as someone who has practiced there for 16 years, we saw months with an NTSV C-section rate that got below 20. It's the lowest months that I've ever seen since I've been there. So it did, to me, show that using standardized communication, adhering to using standard decision aids when it came time to thinking about C-section really improved the care we were giving our patients. And we also did track newborn and maternal outcomes from a clinical side. Those were not altered during the time that we did TeamBirth. But truly the biggest thing, I think, for patients was wonderful to finally include them in the conversation. And I think for nurses, it was so many fewer phone calls. I have to say, it's a lot less pages. So I know I could talk TeamBirth forever. Trisha's probably like, okay, we're done with you.
No, I love it. I appreciate it. Thank you so much, Dr. Chien. That's really great feedback and perspective. I am curious from a provider perspective, and you can put the good with the bad. So what were the challenges, but also what were the positive takeaways from your peers and as they were considering, TeamBirth and implementing?
I think that, as with every QI project, there's always going to be the go-getters, and there's always going to be the laggards. And I think the kind of go-getters right away, they felt like they could see benefit in just this better form of communication. And then, with the laggards, I had to kind of show them, like, what's in it for you. And I think sharing the stories of how much the patients appreciated the process of TeamBirth and being included in huddles was pretty inspirational for the laggards, especially when the ones who are kind of doubting Thomas's, but then went ahead and used the whiteboard and did huddles, when it was one of their patients who came back and said, I had this great labor experience, even though I had an unexpected C-section, I understood why it had to be done, and I felt included in the decision. When physicians hear that, and then they say, okay, the way I communicated with the patient that time was really effective. So I think that's one of it, is to just say the physicians need to hear feedback as to what the benefit has been to the project. And then over time, I think they realize too, you get fewer phone calls. You really do. When you have set the stage nicely and you've answered every question you could possibly answer during your 5-minute huddle, you're not getting the phone call 16 minutes later about, oh, we forgot to talk about this. Like it just tends to really make the care much more streamlined. So I think those were probably the biggest benefits that we saw right away. And then over time, when we had data to show that it did seem to be impacting our C-section rates, I think that was really positive as well.
Oh, that's great feedback. Okay, now we've heard some of the great success that you had with TeamBirth. I'm curious if you wouldn't mind sharing very realistically some of the challenges that you experienced along the way.
I think the challenge is when you're a busy unit and you have providers who have more than one labor at a time, it can be kind of challenging to get them to the bedside in the middle of the night. It was a little bit of a challenge to do the huddles by phone. You know, what I had to ask for is I would say, okay, page me. You need to not put me on speakerphone till I tell you that I'm ready to be on speakerphone with the patient. So some of that was challenging. And I think sustainability has been one of the bigger challenges. It is behavior change. It is very much, I think, kind of nurse driven. The nurse has to be the one to kind of really say, okay, we're going to have a huddle. At least that's what I have found to be more effective for us. So it's hard to change behaviors. I think it's hard to convince people that doing this form of communication that's more open and writing on a board and really including a patient in a different way, you have to convince them that this is different than what they've been doing in the past. So for me, this project came after I'd already been practicing for 18 years. And I was like, oh, well, I do that. You know, I always ask the patients. And then I realized that, oh, well, I'm not sure I did always ask the patient. Like I would have the nurse say, oh, tell the patient I'm going to come break her water. And then the nurse at the bedside would sort of translate that to the patient. And then I would run in and just break water. I'm not sure I ever had as much conversation as I had when I truly adopted the TeamBirth method. So you have to, I think it's hard to get providers to acknowledge and be humble enough to say, I really haven't been doing this as well as I could have, and I think this is better. So I had to eat a little bit of humble pie.
And how did TeamBirth help with that systematic approach? Like is it an automatic reminder? Is it, or like you said, it's a behavior change? How did TeamBirth impact that modified communication change for you personally?
I think for me personally, just having to physically knowing that the board had to be updated, it then became systematic. Like that if I was a new provider coming into the room, I made sure I kind of looked around the room to see who my team players were. I would glance at the sort of birth preferences to make sure that I really knew if there was, something on there. And if there was something on there that wasn't clear to me, I would try to address that the very first time I met the patient, rather than waiting until, they were pushing to say, now tell me again why it is you don't want me to use a vacuum. Like that, that's something I very systematically would go through the board from the upper left corner down to the birth preferences through the plan, and then commit to this is the next time I'll be checking in on you. So it did make it very systematic. And then I think, when we got better at using the delivery decision aids, when we were getting, to any point where we were talking about C-section, very systematic approach of explaining to patients, here's the guidelines that we use. Here's why we as your care team are starting to think about C-section, and really getting them involved in the conversation earlier. So it has been helpful, I think. It then also reminds me every time I do a whiteboard huddle to put a note in the chart and and document that. So.
No, that's great perspective. I'm curious if you wouldn't mind sharing a little bit more. Now, knowing that the delivery discussion guide and the admission discussion guide are optional add-on tools, so not necessarily every hospital will be implementing them, but from your perspective, what was the greatest value for the patient from those tools? And maybe even as a team perspective, like how are those tools instrumental with team dynamics and communication and then patient understanding?
I mean, I think it's helpful because the tools are written to be patient facing, which I think is a unique thing. They're meant to show the patient to say, okay, here's where we're starting to think about your cervix has now been 8 centimeters. It's been 6 hours. If you look at these guidelines, and they're written out for them. So the patients then, I think, really understand that we're not making this up, that this is standard guideline that we all adhere to. And then, and I would say for the nurses too, it's helpful to have those. I will vividly remember, this was during TeamBirth. I had a patient who was stuck at 7 centimeters for nearly 4 hours. And the nurse said to me, she said, well, but the baby's looking fine, mom's doing fine. Can we have a conversation about whether we just keep trying? And so we had this, conversation with the mom and family, and the mom said, I want to try for 1 more hour. And the nurse did a few position changes, and we pulled out the decision aid to say, this told the patient, this is why we're starting to talk about it, because we're now getting close to 4 hours at 7 centimeters. And now we would normally kind of think about C-section, but using the guide and going through the process of saying, well, but the mom's looking okay, baby's looking okay. Can we give it more time? And 42 minutes later, she was complete, and she pushed 21 minutes and had a baby vaginally. And I think this was, again, you standardize the care. It's a reminder to everyone in the room that we have guidelines, but that if the mom's looking okay, the baby's looking okay, there's room for discussion and to really make the patient feel included in the plan. And it was a great outcome. The nurse was kind of grinning at me. This was pre-COVID, so we weren't wearing masks, but I was like, she's kind of grinning at me like, I told you so. But I do think the decision aids are very helpful. It reminds everyone in the room sort of, these are our set guidelines, and then let's have a conversation about what the next step is going to look like.
That is so helpful. I really appreciate that. I did see, and I just wanted to recognize if Barbara or Denise, I see you guys both came off mute. Did you guys have anything you wanted to add or ask?
Well, I just wanted to add to what Dr. was saying when she was talking earlier about, the provider having good feedback from the patients about this being a good birthing experience. And I think also the not having as many phone calls, but it is so much easier to head this off in the beginning and have those discussions than to later have to go in and have a discussion during the postpartum period about why did we do this? And now she's unhappy and questioning why these things were done, and you're having to backtrack and cover it. And it's just so much easier to be proactive and have that discussion up front instead of having to cover what you did and why you did it prospectively.
Yep.
Yeah. No, absolutely. You're right. Getting the team all on the same page before it even ever becomes, a dissatisfaction opportunity for the patient. I agree with you, Barbara. That is one thing that I did want to explore a little bit further, Dr. Chien, was the patient survey and the feedback and how that was helpful with implementation for your team. So that is an option for these hospitals to add on the research component and to do the postpartum surveys. But I would love for the hospital systems to hear how maybe perhaps that was valuable, not just for your team morally, but for morale, but also for implementation and motivation. Do you have any reflections on that?
Yeah, I think for us, the patient surveys was important because, again, it sort of falls into the why are we doing this? Why are we undergoing this, big behavior change, right? In the end, we're all committed to better maternal outcomes. We're all there to give our patients the best care. And then, but I think the only way, we have objective measures of, care, like did the mom go home healthy and was the baby okay? But I think the more important thing though is, but what was the patient's perception? Like, do they feel like they were involved? And I think it's having that feedback and having them tell us, like, yes, I remember the huddles. I think it validates that having the huddles are important and that the patients remember that there was a huddle and that they felt involved in their care. Like that, I think is so important. When you look at maternal mortality nationwide, I think the reason we struggle with maternal mortality is because we haven't been the best at empowering our birthing women or birthing people to question the care they're given and to question what's happening to them. And I think using TeamBirth and kind of hearing the feedback from these surveys to see that there is an impact, it is worth all the efforts if you get the patients to say, yes, I feel that I was heard in this decision process. Yes, we had huddles. I think that feedback is really important, because unfortunately, if you get patients who then say, oh, I don't remember the huddles at all, then you kind of say, okay, does that mean it allows you to regroup to say, well, are we not doing them in a way that the patient understands this is what we're calling a huddle? Are we not really including them in the conversation, which then defeats the purpose of whiteboarding, as I call it. I've now made whiteboarding into a verb. I call it whiteboarding. But, I think the feedback allows you to sort of tweak the process to say, what are we doing well? What are we not doing well? What is helping the patient? What is not helping them? So you know how to concentrate your efforts as you continue to roll out the process.
That is an excellent perspective. I'm also curious if you have any just very specific examples of maybe one of your own patients that experienced TeamBirth, and if they reflected kind of in their own words what the difference was or what the impact was for them.
I did have a patient who, in her birth preferences, she was very, very petrified of a postpartum hemorrhage. I think she'd had a family member who had nearly died from a postpartum hemorrhage. And so, having that information, I think, set the stage for us to know that if we started to see more bleeding, this was a patient who wanted us to tell her. She said that. She said, please don't not tell me if I'm going to bleed to death, which was really like, this was, I think, an extreme case of a patient who really harbored that fear. And she hadn't really mentioned it to me prenatally. Honestly, she was my own patient. She hadn't really told me that until we sat down to go through the board. And I said, this section is for you to tell me what you hope happens for your birth, but also to tell me what you're very, very fearful of. And she just said, I don't want to die from bleeding. So, and then it turns out as her labor progressed, she had really, really vigorous bloody show. She was petrified every time she saw the blood. She needed a lot of reassurance. And I think having us have more frequent huddles to reassure her, I think made that birth experience really good for her. She did end up having a little bit more bleeding, but we started more uterotonics and she understood right away. And I told her, I said, we're being aggressive with getting your bleeding to slow down because you have told me that this is a fear of yours. So we're going to be, really on top of it. And this is why we're doing all of these interventions. And so I think that TeamBirth board really set the stage for me to give this patient a different birth experience than she would have had if I didn't have that board.
Yeah, that's a great reflection because you what that patient's fears and needs were and tailored her entire care experience specifically to that. That's wonderful to hear. I do want to go ahead and just briefly pause and invite anybody. I've been throwing many questions at Dr. Chien, but is there any questions that any of you have currently after listening to this conversation? Please feel free to come off mute or even write them in the chat, either way. It looks like Sarah Shockley, did you come off mute and did you have any reflections or questions?
I did not come off mute.
Oh,
on purpose.
Okay, no problem.
And I have Dr. Galan. We're doing a speakerphone thing here. We couldn't get his computer to work, but he's also with me, just FYI, and he has nothing to add.
Okay, wonderful. Well, if you guys come up with anything or if there's anything that Dr. Chien says that kind of triggers a question, please feel free to jump off mute and ask. And Sarah, tell me what physician is in the room with you?
Dr. Renee Galan.
Galan. Excellent. Thank you, Dr. Galan, for being here. Thank you for modifying your technology to support you guys to be together for this call. We appreciate it.
Yeah, thank you guys.
Wonderful. Well, we can continue, but please, like I said, don't hesitate. We do want this call to be very interactive, and we recognize that, implementing quality improvement in the landscape of COVID is a bit intimidating and also maybe overwhelming. So if you have any big concerns or questions, I can guarantee you there are probably others that have those exact same. So be bold and courageous and just feel free to ask. Go ahead.
The other thing that I found really helpful with TeamBirth is that at the time that we started the pilot project, we had a handful of completely new nurses. And of course they started at nights. They were kind of the new, the baby nurses. And TeamBirth is really, really helpful for new labor and delivery nurses. I think it gives them a platform by which they can ask questions and not feel intimidated, because when the nurses are asking questions, they're often trying to clarify as well for the patient. But, you know, it can be done in a way that where I think they just feel a little more secure saying, okay, Dr. Chien, so let's go, can we just reiterate again? So you want me to check the patient in 2 hours and then start the Pitocin if she's still 6 centimeters. And so by having the TeamBirth board, that new nurse who probably was a little hesitant, maybe didn't really hear what I said or just wasn't sure, had a platform by which she felt safe to ask me one more time. And then it saved me a phone call, I'm sure. So I do think for new nurses, using TeamBirth is helpful to them. And I think for new nurses too, like sort of becoming familiar with labor guidelines and sort of what interventions to be doing for fetal heart tracing, that, you know, as part of TeamBirth, I often would go through them with the patients, sort of like Barbara was saying, better to sort of explain to patients along the way than have to retroactively go back and say, well, this is what happened. And I think for newer nurses, it's very helpful because as you talk through it and say, oh, this is what the decision aid says. When we start to see your baby having these dips in the heart rate, we move you around like a rotisserie chicken. We stop the Pitocin. Sometimes we put some fluid back inside to cushion the baby. Like going through that conversation with the patient, you're then also sort of reiterating to newer nurses, like these are the steps to remember to always do for intrauterine resuscitation. And then now it's on a piece of paper or a piece of laminated paper as well. So it's very handy for new nurses, I think, personal opinion.
No, I agree completely with you, which is so relevant to our current state, which is we do have new nurses. I know that your facility, you said that you have travel nurses and a brand new experienced nurses. Do you have any reflections on that?
Well, right now we have 27 travelers. And when I was on call a week ago, I, of course, had a completely new traveler who I hadn't ever worked with before. But again, whiteboard was very unifying. Like it actually, I loved it because, you know, we could just really go through the plan, and she didn't know me. So she was able to ask me and include the patient in the conversation to say, well, you know, Dr. Chien, do you want me to check her, or are you going to come back yourself to check her? So it again was helpful for us to figure out practice styles because she didn't know if I was a checker or a not checker. So I think for travelers, you know, it's also, again, helpful. They don't know the providers. And so rather than have the travelers have to sort of make assumptions based on their experience at other institutions, you can better outline for them sort of what you want to do at your institution. I think it's very helpful for them as well.
Absolutely. So now thinking about maybe perhaps some hospital systems might have a concern with physician buy-in. Do you have any strategies or recommendations on how teams can support physician provider buy-in?
I think it's having the champions, really, you know, finding the physician champions, the ones who really have embraced the concept, to go talk to them to say, how can I help you, you know, figure this out? And what are the barriers for, you know, for you having these huddles? And again, I think, you know, even for us, like the laggards turned around pretty quickly when they started to see how much the patients really embraced it. And I have to say now, you know, I go back whenever I'm on call, like I bring my own dry erase markers. I'm kind of weird like that. I bring my own whiteboard tools, I call them. And I think, you know, when you look at sort of in the bigger picture, what I try to remind physicians is that a lot of patient dissatisfaction or happens when there's an unexpected outcome and they don't understand what happened. And so this is a really important way to keep your patients in the loop so that hopefully at the end, if you have an unexpected outcome, you don't have a patient who's like, well, that doctor didn't tell me anything, right? And I think that's sort of if you have the people who are like, oh, what's in this for me? I'm like, it's going to hopefully keep you out of hot water, because we know all the bad outcomes that lead to litigation. It's often because the patients feel they weren't communicated to and that things were done to them and not with their permission. And I think this is a way to just really develop that trust relationship. And then for physicians who are laboring patients of their partners or patients they're meeting for the first time, I think it's a really excellent way to develop a relationship from the beginning, to say, I'm here for you. I'm here to take care of you. I'm here to listen to you, even though you just met me 10 seconds ago. So I think it really develops a connection with every patient when you come in and you listen to them and you include them in their care in a way that is different from how we've done it in the past.
Yeah, and it automatically invokes trust and
Yes.
safety and promotes safety. Yeah, no, that's a great reflection. Barbara, did you have anything to follow up there with?
Yeah, I wanted to, I think that's so important what you just said, Dr. Chien, especially about the patient feeling like things are being done with them instead of to them. And so many times when there is an unexpected outcome, patients say, well, I didn't even know I had a choice, and so many things. So, you are bringing them into the call or into this decision making early in the process. And I wanted to bring up when you were talking about the nurses and how on a previous call, I really liked one of your statements that you said, and you can comment on this, you didn't realize you'd been using nurses as your translators.
My translators. Yeah. And I think that's true. The nurse would call me and tell me a patient had been admitted, and I would tell the nurse, okay, well, can you just tell her that I'm going to come in an hour and check her and break her water, or we could start Pitocin. And then I would hang up the phone. And maybe that's just me, but I think a lot of physicians, if they're being honest, that's kind of been our style. We're busy. We're trying to run labor at the same time that we're doing clinic, or we're running several labors at a time. So my expectation is that after I hung up the phone, the nurse would then translate to the patient what I had said on the phone and get them kind of ready for me when I came in. And what I found over doing TeamBirth is that having that conversation with the nurse on the speakerphone and including the patient was just so much faster for me. And it is true what you're saying, Barbara. Patients, when we started doing TeamBirth and I started being much more prescriptive about even asking, like, how do you feel about having your water broken? And I was pretty surprised how many patients said, well, what can you tell me what the pluses and minuses might be? Because and I think in the past, what typically would happen is we would go in and say, well, we're going to break your water now to just get your labor going. And any physician who says, oh, I don't do that, I always ask, I'm like, I don't know if I believe you, right? Because after 18 years, I usually would just walk in and expect the nurse to have already told the patient like why I'm coming to break water. But when you get stopped by the first patient who says, well, can we talk about it? Do I have to have my water broken? And you realize that, like, okay, this is something that matters to this patient and I need to have that conversation. And then I'll say the next time you prolapse a cord, you're then very grateful that you talked to the patient about pros and cons of breaking their water and that, there was this tiny risk of cord prolapse and you've had that conversation. But it is interesting how it changes. You kind of, instead of playing telephone with the nurse, you just have a three-way conversation on the phone. It takes a bit of getting used to, not gonna lie, because it's different than what we've done.
Yeah, no, that's helpful. One thing I did want to kind of provide the opportunity. So Sarah Johnson works with OPQIC. She's the maternal peer navigator. And one thing you had said, Dr. Chien, was that it really provided patients the opportunity to fully understand. And even if that meant like there wasn't the outcome that they were wanting, they were brought along. And Sarah, I didn't know if you had any reflections, because I know you work with and maybe you could share the work that you do with women who have had an adverse outcome and just kind of what your reflections on how TeamBirth could have potentially modified your experience.
Sure, Trisha. Thanks for giving me the opportunity. And yeah, you kind of just nailed it. And I won't deny the fact that listening to you talk about this, Dr. Chien, gets me a little emotional because after my experience with childbirth, I left there with so many questions. I had so many questions about what had happened to me. I really had no explanation. And when you leave with so many questions, your mind, it tends to go to the place of, well, what could they have done differently? So the fact that you mentioned that and how using the whiteboard and the communication style, including the patient in the huddle, would really eliminate a lot of those communication errors. I have to say, yeah, I completely agree with you. And I think that if I had had this experience during my childbirth, I would have had a completely different perspective, even if the outcomes would have been the same, even though the outcomes may have been the same. I would have had a completely different perspective about what had happened. And I will say that we have a small group of women who work with me. I have a patient partner network of other women that work with me here in Oklahoma. And we have talked about TeamBirth. They understand the process. We talk about it quite a bit, and all of them agree. They all feel the same, and they had very different birth experiences, and so they all feel the same, that if there was better communication, they would have left with a better perspective. So I just wanted to add that, and thank you guys all for attending. We are really excited about TeamBirth from the patient partner's perspective.
Yay.
Thank you so much, Sarah, for sharing that. I really appreciate it. So Dr. Chien, another comment you had made that I kind of want to investigate a little bit further was you said that huddling either in person or on the phone, it is a behavior change and it takes time getting used to. Is there anything you dislike about huddling?
I mean, not really. I think at first it was, I sort of was worried like, oh, is this going to take me a lot more time? But really it doesn't, because there's so much time saved, I think, on, having to answer questions later. I mean, I think, yeah, I mean, I don't know. I feel like the huddling it did take some time because it was just a different thing. We've gotten so used to just communicating on the phone with nurses. I think bedside medicine has, to some end, unfortunately, kind of gone away. And then when you have electronic medical records and everyone can look at fetal heart tracings remotely, you can do a lot of that by the phone. Like back in the day when I started, there was no such thing. I had to walk in the room to look at the paper. So I think we did much more bedside talking. And then I think when everything became computerized, it actually allowed for more remote care. So I do think huddling really, it takes some time and it feels different, but it is nice to get back to bedside medicine, I have to say.
No, that's great. I think that is a common theme that we have heard nationally whenever we talk TeamBirth with hospital systems, is a provider fears that it's going to take more time. And we recognize the incredible busy schedule that you have with balancing labor, the surgical OR, and also your clinic. There's just so many demands on you. So that's good to hear your perspective that you don't believe it does take more time. In your experience, it doesn't. How about culture? Was there anything at your facility that changed, like within your facility with the culture on your unit, like with nurse physician interactions, or anything to reflect on there, how it may have impacted your team?
I think that, when you look at OB, the nurses really do, so they're really responsible for so much of the bedside care. And I feel like TeamBirth was so well received and embraced by the nurses. I think nursing morale was much better. I think they feel like communication with all the providers was enhanced with TeamBirth. Again, it gave them a platform by which to ask for clarification without feeling nervous about it. So I do think that, the culture on our unit at the time that we were really embracing TeamBirth was a really good one. Morale was good. And I think the nurses felt like we were finally giving the kind of care that people giving birth should be getting, you know, with better communication.
Now that's great to hear. And right now with the fatigue of COVID, and I know we've heard morale has been low,
Yes.
TeamBirth might be an opportunity to kind of just really help teams have a win and boost morale. So that's a good reflection. Good to hear.
Mhm.
So I do want to pause again, and I'm going to actually call out the, there's quite a few people here from the Ascension St. John team. Do you guys have any questions for Dr. Chien? Have you heard any like common themes or concerns, maybe from your provider's perspective, that you would love to hear insight from Dr. Chien that you could share with them? Dana, I'm going to call on you, or Jenny.
I think the common theme that I've heard most is how much time it's going to take for the providers to stop and do this, especially like on the postpartum side, which is the area that I'm responsible for. So I was very encouraged to hear, Dr. Chien, that you learned over time that that really was not the case, that it created or demanded more of your time throughout the day.
Yeah, I just think that, you know, it's because you're all in the room together. So everyone's questions get answered at the same time. And and you know, what I also had to reflect is at one point I found myself having to stop to say, wow, even if this adds 30 minutes to the care of a patient during their labor and their postpartum, like, don't our women deserve that? You know, I had to really reflect on that and say, it's unfortunate that the economics of healthcare and of maternity care have driven physicians, midwives, everyone to feel so strapped for time that, you know, we consciously think about, oh, this is taking so much time, but you're like, wow, this person just got a new human. Like, don't they deserve that little extra bit of time? I think it's unfortunate that we all feel so strapped that we have to think about that. So anyway.
Jenny, any other thoughts there or any follow-up comments?
Well, another thing I was excited to hear you mention was in my area in particular, I have a mix of very experienced nurses and then also a handful of less experienced nurses. And of course, naturally, the less experienced nurses are more hesitant and fearful to call the physicians.
Yes.
And a lot of that population exists on the night shift. So then you're even more reticent to call and wake up a physician in the middle of the night because you don't want to upset them. So, you know, they're just in the early stages of their career trying to build their confidence as a nurse and then trying to communicate and articulate what they need to properly in the middle of the night. They're just scared to death to do so. So sometimes they just don't when they should. So I think for my area in particular, that this could really help improve, number one, the relationship between the newer nurses and the physicians, and then remove some of that fear, you know, when you're all in the room there together, communicating what the plan is going to be. And like you said, in the long run, it's going to decrease those phone calls too. So I'm excited for that aspect of it.
Yeah, and I think really the patients so love it. The patients really enjoy feeling more included in the conversation. It's, you know, it is very, very humbling, I think, for physicians to have to reflect and say, yeah, I probably wasn't the best at doing that before. And I think it's only when you really start doing huddles in the way where you actually turn to a patient and say, does this make sense to you? Is there anything you want to add? Do you have any concerns? When you actually really include them in that way is when I think you realize, like, I don't know that I did it this way before, but patients really appreciate that.
This is great conversation. And Jenny, I really appreciate you coming off mute and just sharing your questions and reflections. I do want to be mindful of time. I had written down in my mind that we were going until 2 o'clock and it's actually till 1:45. So in a grave desire to be very respectful of everybody's time, any last questions, or Barbara, if you have anything you wanted to add, or Dr. Chien, if there's anything we didn't cover, just any last reflections before we hop off the call?
I'll just say one thing, because I know I've gotten questions about participating in the research and the IRB process and all of that. You know, Ariadne will work with you so that the work on the hospital end is not significant for that. But the patient comments, you know, Dr. Chien talked about how much the patients like it in those comments. They're truly heartwarming and really are motivational for your team, for everyone on your team. To, you know, I always say nurses make a difference, and so do the doctors, and this really helps you to feel that, how much of a difference you're making. So I think it's just really important. We thank you again, Dr. Chien, for being so willing to work with us here in Oklahoma. And do you have anything else you'd like to say?
No, I mean, it's tough, you know, it's tough. You're implementing big behavior changes. But it's really worth it. You know, in sharing and, you know, sort of my full disclosure, like, you know, it is, I wish this would become sort of the national standard and how it's taught in medical school and residency, so that it's not a project or something temporary, because I think this is the way birth should be done. At my own hospital, it's been a little bit of a struggle because of COVID and the turnover of staff. And the nursing morale is low, but you know, we're getting back on board. We're whiteboarding again, because we can see that that's going to be the key to getting our morale back, is to going back to sticking to consistently using the whiteboard, even with our new traveler nurses and all of that. So it's, you know, it's a process, but at some point, what I would say is, you know, it's probably the way it should be done. And at some point, we hope that it'll just be the way it's taught from the very beginning.